Hello and welcome to the second part of the 10 things you didn't know about severe head or brain injuries in intensive care that you must know, especially if your critically ill loved one is not waking up, or even worse, if the intensive care team suggests a withdrawal of treatment or a limitation of treatment for your critically ill loved one. Let's move on to number 5. Why the intensive care team's judgment about future or perceived quality of life may be the ultimate determinant in how they present and position your critically ill loved one's diagnosis and prognosis. If you have read some of my other ebooks, or if you have watched some of my other videos, you would have heard me talking about quality of life or even perceived quality of life. And if your critically ill loved one is in intensive care with head or brain injury, the intensive care team will base many of their decisions on the perceived quality of life of your critically ill loved one in the future. That's a triple hypothesis there, and that's what the intensive care team often bases their decisions on. With triple hypothesis, I mean that the intensive care team is basing their decisions on the future, which is a hypothesis about something that may or may not happen. They base it on their perception. It's a perception and it's not even real. And about quality of life. Quality of life is the quality of life of an individual that cannot be measured, and who is the intensive care team to judge the perceived quality of life of somebody else in the future. The fact of the matter is that the intensive care team is basing their decisions on something that is entirely hypothetical and up in the air, and it also means that they are making judgments about what they think people are prepared to put up with or to live with in the future. The future is often in the intensive care team's hands, especially if families of critically ill patients in intensive care have no peace of mind, no control, no power and no influence, if they don't know how to manage the intensive care team. Therefore, I believe it's highly irresponsible and highly unethical that the intensive care team bases some of their crucial decisions that decide about death or life on their perception about future quality of life of your critically ill loved one. The reality and the fact of the matter is that the intensive care team are the experts in intensive care, but they are not the experts about perceived quality of life in the future. The intensive care team's job is to save your critically ill loved one's life no matter what, and the intensive care team's job is to get your critically ill loved one's life out of intensive care alive. Sometimes you have to remind them of that, because the intensive care team's strictly academic point of view gives them the perception that they know it all. You and your family also need to simply ask what quality of life means to you, to your family and to your critically ill loved one. It's a very subjective and very individual question that only you can answer for yourself and for your family. You may even have to answer it for your critically ill loved one, depending on the circumstances. But the intensive care team are not the ones who can answer it for you, even though they think that they can. The reality and the fact of the matter is that once a patient has left intensive care, the intensive care team often has no idea what this quality of life looks like for your critically ill loved one, because the intensive care team has no idea what's happening outside of intensive care. Once again, they are the experts in intensive care, and they are not the experts about quality of life outside of intensive care. Because I also work in the community with intensive care patients in their home that are long-term ventilated with tracheostomy, I know what some people are prepared to put up with and still have quality of life. You would be surprised how many grateful people are at home, alive and happy to be at home on a ventilator, and their families are happy too, to have them around. You can check out intensivecareathome.com.au for more information there. I'm not saying that this is the ultimate end goal. However, what I'm saying is, don't let anyone tell you what a future perceived quality of life needs to look like, because it probably won't fit your perception about future quality of life. Let's come to point number 6. Why the intensive care team's judgment about future or perceived quality of life may be the ultimate determinant in how they present and position any future treatment and care your critically ill loved one may receive or not receive. Just like in the previous point number 5, where the intensive care team is making judgments about the future perceived quality of life of your critically ill loved one who sustained a severe head or brain injury, the intensive care team will therefore also implicitly or explicitly decide on the treatment and the care they are going to give to your critically ill loved one based on their judgment and perception about future perceived quality of life. The reality and the fact of the matter is that behind closed doors, the intensive care team will work out their positioning. They will work out how they present and position your critically ill loved one's diagnosis and prognosis, and they will work out how they can convince you to play along with all of that. I have seen some critically ill patients in intensive care with severe head or brain injuries that have just come out of an induced coma and they weren't waking up straight away, and therefore the intensive care team knows from experience that waking up can take a long time, and waking up is also not guaranteed. That doesn't mean, however, that it's not achievable. Furthermore, if the intensive care team sometimes doesn't want to invest the time, the money, the resources, and most importantly, the emotional energy that it inevitably takes to get your critically ill loved one with a severe head or brain injury out of intensive care alive, they will just minimize their efforts without you even noticing. For example, if the intensive care team's agenda is to have an empty bed available as soon as possible because they experience a high demand on their intensive care beds, they will inevitably start with quote-unquote emptying the beds with the most vulnerable patients. And the unfortunate reality is that severe head or brain injuries tend to be some of the most vulnerable patients in intensive care. By preparing you and your family, and by telling and quote-unquote selling to you that a withdrawal or a limitation of treatment may be in quote-unquote the best interest of your critically ill loved one, because the intensive care team thinks that your loved one wouldn't have any future quality of life. They only tell you a one-sided story, and they are not even talking about giving your loved one more time, a genuine opportunity, and the time they need in order to recover and in order to wake up. As I have pointed out in number 4, a positive culture in intensive care goes a long way and generally facilitates better patient outcomes. However, you also need to be mindful of the competing interests in an intensive care unit, because the reality and the fact of the matter is that if there are other patients in intensive care needing expensive and scarce resources, and if the intensive care team has a bigger interest in treating those other patients because of medical research interests, or because they are dealing with other families of critically ill patients who are more demanding, who ask the right questions, and who have control, power, and influence, then your critically ill loved one's treatment care may simply suffer. The reality and the fact of the matter is that as soon as you start asking the right questions, as soon as you start to notice what's happening behind the scenes, as soon as you start to become aware of the competing interests that the intensive care team may have, and as soon as you start to become more difficult and demanding, that's when you will have control, power, influence, and most of all, peace of mind. But the bottom line often is that if the intensive care team thinks that your critically ill loved one has no future perceived quality of life, then they may silently not offer full or the best treatment, and they may even silently and quietly document in the medical notes that your critically ill loved one is not for resuscitation in case their heart would stop. That's how often arrogant and condescending some intensive care teams can be. They often make decisions behind closed doors without even informing you because of their competing interests, because of their often strictly academic view, and because of their hesitancy to overcome their negative culture and have a more positive outlook, because a positive outlook can make all the difference. Let's go to number 7. Why the intensive care team may suggest that a withdrawal of treatment or a limitation of treatment may be quote-unquote in the best interest of your critically ill loved one, and what they really mean when they say it. As I have pointed out before, critically ill patients in intensive care with severe head and brain injuries tend to belong to the most vulnerable group of patients in intensive care. Why are those patients with severe head and brain injuries more vulnerable than other patients in intensive care, you may wonder? Well, critically ill patients with severe head and brain injuries are more vulnerable compared to other patients in intensive care simply because the head and the brain have a life on their own, and the outcomes for critically ill patients with severe head and brain injuries are never linear, straightforward, or even predictable. If you think about it, if someone is being admitted to intensive care with pneumonia, with kidney failure, after open heart surgery, etc., etc., those patients, generally speaking, go through similar stages in their journey in intensive care, generally speaking. Those patients sometimes are even on clinical pathways, and if the intensive care team follows those pathways, patients have a good chance of leaving intensive care alive and in a relatively short period of time. Of course, there can be complications, and then patients can deviate from those pathways. However, it's far less common that patients deviate from what is expected. Those patients, therefore, are not as vulnerable as patients with severe head or brain injuries. There are no pathways for severe head and brain injuries. The reason for that is that simply the brain has a life on its own, and we know far too little about the brain compared to other organs such as the heart, the liver, the lungs, and the kidneys. You see, those organs have a mechanical, physiological, and almost technical function. Pretty much every one of those organs, the heart, the liver, the lung, the kidneys, has the same functionality in all humans. However, the brain operates differently in every human being. If you think about it, how many people do you know that are not like you, that are totally different from you? You probably know many people who are not similar to you. What's the main difference? It's their behavior and their thinking that makes them different to you, which stems from the brain. Those people's heart, their lungs, their liver, and their kidneys do exactly the same than they do in your body, assuming that you and the other person are healthy. However, the way those people operate on a mental level is very different from you, and the difference is in their thinking and in their brain. This, one way or another, has implications on the recovery of critically ill patients with severe head or brain injuries, because the brain operates so differently on many levels in different people that it therefore makes the recovery process in severe head or brain injuries unpredictable. In my experience, after more than 15 years intensive care nursing in 3 different countries, most critically ill patients in intensive care with severe head or brain injuries will not follow a pathway, and they will never follow whatever anyone might be expecting. It's therefore that critically ill patients in intensive care with severe head or brain injuries are so vulnerable, especially if they are not waking up in a time frame that is acceptable to the intensive care team. And with acceptable, I mean that the intensive care team might give your critically ill loved one a couple of weeks to wake up, which in the bigger scheme of things is not a lot of time after a severe head or brain injury. Because as I have pointed out before, some intensive care units and intensive care teams give critically ill patients with severe head or brain injuries the time, the nurturing, the care, and they often have an inert belief that those patients will wake up and will recover. Many other intensive care units are quite strict and far more negative in their outlook when it comes to severe head or brain injuries, and the intensive care team may be quick to point out that a withdrawal of treatment or a limitation of treatment may be, quote unquote, in the best interest of your critically ill loved one. The reality and the fact of the matter is that some intensive care teams are simply not prepared to put in the money, the resources, and most importantly, the emotional energy in that it takes to let your loved one wake up in their own time. Because from my experience, time is the ultimate healer. I can also tell you from experience that every intensive care unit who is having a long-term patient with a severe head or brain injury that isn't going to wake up quickly is taking its emotional toll on the staff and also on the family of that critically ill patient. It's quite a journey, and it can be emotionally draining. Sometimes the intensive care team may have had emotionally draining experiences with severe head or brain injury patients in the past that they consciously or subconsciously have in the back of their minds, where they have been traumatized as well, and they therefore don't want to go through the experience again. That doesn't mean, however, that the intensive care team shouldn't give your critically ill loved one with a severe head or brain injury the best of treatment and care there is, and the time and the nurturing that it takes to wake up and recover. I'm just listing and explaining to you some of the underlying reasons and the psychology why the intensive care team may suggest to you that a withdrawal of treatment or a limitation of treatment may be, quote unquote, in the best interest of your critically ill loved one. The reality and the fact of the matter is that too many competing interests may well be in the way of giving your critically ill loved one a fair chance to recover and survive. And as I have pointed out, the intensive care team also needs to invest some emotional energy in the recovery of your critically ill loved one. Let's move on to number 8. Why your attitude, your outlook on life, your resilience, and your level of control, power, influence, and peace of mind may be your biggest leverage point in this difficult and challenging situation. What do you think is your deepest source of wisdom? What do you think is going to happen? How do you think your critically ill loved one will fare? Have you, your family, and your critically ill loved one overcome massive challenges in the past? I bet you have. How did you overcome these massive challenges? Do you think that some of your ancestors that you may have never met have been in difficult and challenging situations during times when life was a lot harder than it is today? Do you think that you, your family, and your critically ill loved one are resilient? Do you think that your ancestors have been resilient? I think I can sincerely assure you that you and your family are resilient, because the reality and the fact of the matter is that if you are here today on this planet alive, it's a miracle, and you wouldn't be here today and watching this right now if you and your ancestors hadn't been resilient. Just imagine centuries of war, famine, mass epidemics, etc. And you are still here today. That's a miracle, isn't it? I think that we highly underrate the challenges that our ancestors had to overcome in order to survive during times when there was no electricity, no cars, No trains, no airplanes, no internet, let alone hospitals. We must start putting things into perspective, and we must acknowledge and pay tribute to the fact that our ancestors paved the way for us to be here today alive. I think we really have to put things in perspective here, and I really think that we can learn many valuable lessons from some of the challenges our ancestors had to face. Therefore, think of a time when your parents, your grandparents, or even your great-grandparents told you about a time of struggle, a time of war, maybe a time of famine, of a catastrophe, and so on. I'm sure you can learn a lesson or two, and I'm sure you can find some strength in the resilience they have shown. Maybe you don't need to go that far back, and maybe you have been in some challenging situations that you had to overcome, and maybe you can draw some strength from there. Whilst you can't control the intensive care team's positioning and their attitude, what you can control is your attitude. You are in total control about your outlook on life. You know how resilient you are, and you also know that your critically ill loved one is far more resilient than the intensive care team thinks they are. What story has inspired you from your own family, how they overcame an obstacle, some struggles, or a big challenge? What story inspired you from other people, how they beat the odds, and how they overcame insurmountable obstacles? Do you think there are some lessons for your situation? I bet there are. Let's move on to number 9. The brain has a life on its own and is the organ of the human body that we know very little about compared to other organs such as the heart, the lungs, the liver, or the kidneys. Therefore, a lot of what the intensive care team or the neurosurgery team is telling you could be based on guesswork, as severe head or brain injuries don't follow pathways or clear guidelines. Now, all major organs in the human body are well known, and those major organs such as the heart, the lungs, the liver, and the kidneys have been researched to the point that modern medicine is now even in a position to transplant a new kidney, a new heart, a new lung or liver between humans. That's amazing stuff, and it saves lives. That's good and encouraging news. Why didn't I mention the brain with all the other major organs before? I didn't mention the brain, even though it's a major organ as well, because very little is known about the brain compared to all the other major organs. You see, the brain has a life on its own. If you think about it, every other person on this planet is different from another person. What's the difference? Well, you could say it's their physique, it's their height, their name, their gender, etc. Sure, those things are some of the features that make people different from each other. However, when you are pointing to the differences of another person, very rarely will you point out their height, their gender, or their name as being the point of difference. What will make a person unique and different, though, is their thinking and the way they are living life or the way they are behaving. And those behavioral features have their roots in the brain and nowhere else. The main differences in human beings are in the brain, and therefore the brain is different in every single person. You see, in intensive care, for example, critically ill patients who go through open heart surgery, lung transplants, kidney or liver transplants tend to follow pathways. Those pathways tend to map out the path for a patient's recovery over many days or sometimes weeks. Because those other organs are well known, understood and researched, it's therefore relatively easy to predict the steps of a successful recovery. Quite the opposite is true about the brain. Not enough is known and understood about the brain, and therefore there are no pathways for a successful recovery in severe head and brain injuries. One of the lessons that I have learned in more than 15 years intensive care nursing in 3 different countries is that brain and head injuries are very unpredictable. Severe head and brain injury patients can often in an instant deteriorate quickly, and they can also miraculously recover. I have seen and looked after so many patients with severe head and brain injury in intensive care over those years, and the only commonalities those patients had was that they are very sick and that their recovery is very unpredictable in both ways, positive and negative. I remember some patients made remarkable recoveries after sometimes many weeks and many months, and others who had already been on their way to recovery had setbacks and they deteriorated. But the big difference in the patients who survived and recovered compared to the patients who didn't make it wasn't so much the treatment. The big difference was mainly people's attitude towards their critically ill loved one. The patients who survived and recovered after severe head and brain injuries in intensive care usually had families behind them who weren't giving up. They simply knew that time would be the ultimate healer, and they wouldn't put up with all the negativity and all the doom and gloom from the intensive care team or let it impact on their positive outlook. As I have mentioned before, intensive care teams can be very quick at suggesting that a withdrawal of treatment or a limitation of treatment is quote-unquote in the best interest of your critically ill loved one with a severe head or brain injury, because they simply don't want to have a bed occupied for very long, because they know that there are other patients waiting for those intensive care beds. The intensive care team also often doesn't want to invest the resources, money mainly, and also the emotions that it inevitably takes in order to get your critically ill loved one through this difficult and challenging time. The intensive care team, of course, would never admit that they don't want to spend or invest resources for your critically ill loved one. The emotional toll that it takes to get your critically ill loved one through this difficult and challenging time is a tough one. But once again, the difference to get your critically ill loved one on their way to recovery is, generally speaking, resilience and not giving up in the face of extreme adversity. Don't listen to the intensive care team's doom and gloom if you and your family think that your critically ill loved one will survive and recover. You also need to know and understand that the intensive care team doesn't perceive head and brain injuries as being quote-unquote sexy. They don't perceive that having your critically ill loved one in intensive care for long periods of time with a severe head or brain injury is very fashionable. And as I have mentioned before, the intensive care team is often trying to justify a withdrawal of treatment or a limitation of treatment as quote-unquote in the best interest of your critically ill loved one, because they wouldn't have any quality of life anyway. Therefore, your job is to know that time is the ultimate healer, and you also need to know that the intensive care team is looking for early signs of recovery, because if they don't see those early signs of recovery, the intensive care team will be trying to minimize the resources they spend on treating your critically ill loved one. Therefore, your critically ill loved one may not reach the point where they get a genuine opportunity to recover in their own time. I have worked in some intensive care units where critically ill patients have been given plenty of time to recover with very good results, generally speaking. And I have worked in some intensive care units where the intensive care team, generally speaking, wouldn't go beyond the 2 to 3 week mark for severe head or brain injuries, and the intensive care team would be extremely adept and shrewd at selling to the families that a withdrawal of treatment or a limitation of treatment is quote-unquote in the best interest of their critically ill loved one. The intensive care team would never admit that financial and or bed pressures are the real reasons why they wouldn't continue treating those patients. The intensive care team also would never mention one of their other biggest reasons why they didn't think that continuing treatment would be warranted. As I have said before, severe head and brain injuries are not being perceived as quote-unquote sexy by the intensive care team. The intensive care team, generally speaking, wants to allocate their precious resources towards patients where they can do medical research that attracts 5, 6 or even 7-figure funding per year. The intensive care team also tends to focus their interests more on the technical stuff such as ECMO, balloon pumps, amongst other forms of fancy equipment such as ventilation and or VAT devices for the heart. You really need to understand what's happening in an intensive care unit on a deeper level so that you can position yourself and your critically ill loved one's prognosis and diagnosis powerfully. Let's move on to our last point, number 10. If your critically ill loved one after a severe head or brain injury is really dying, know that an end-of-life situation, even for intensive care patients, can be done at home, where you and your family can have more control, power and influence, and most of all, peace of mind. Now, if you, your family and your critically ill loved one are in the situation where your critically ill loved one is inevitably approaching their end of life in intensive care, and you and your family know that it is the only option after you have done your own research here at intensivecarehotline.com. If you have done your own research and you have come to the sad and tragic conclusion that your critically ill loved one is inevitably dying, you still want to have peace of mind, control, power and influence. Now, if I had $1 for every family in intensive care who asked the intensive care team whether they can take their loved one home in an end-of-life situation, I would certainly be a millionaire, period. It's a recurring theme in intensive care that families of critically ill patients who are approaching their end of life want to take their loved one home, only to find that the intensive care team and or the hospital has no interest in providing such services, even though they would vastly profit from those services by improving their reputation by providing a far more patient, a far more family-centered and a far more dignified option for your critically ill loved one to die at home. They would also be in a position where they can empty their beds earlier and reallocate those resources to other critically ill patients. And they would be saving money and resources because home care tends to be far more cost effective compared to a bed in intensive care. Now, most surveys in Western countries suggest that if given the choice, 75% of people want to die at home. The reality, however, is that less than 20% of people are actually dying at home. The rest is dying in hospitals, nursing homes, etc. The good news is that in some countries, intensive home care services provide the opportunity not only for long-term ventilated adults and children with tracheostomy to go home, they also provide the opportunity for dying patients to approach their end of life in a private, dignified and patient and family friendly environment that is home. You can check out intensivecareathome.com.au for more information about intensive home care services. That's intensivecareathome.com.au. Those services provide patients and families with what they want most, which is peace of mind, control, power and influence. And often, if you can have your loved one at home when they are dying, you can create better memories of the situation, rather than letting them pass away in a sterile and hospital environment. I have personally worked with long-term ventilated adults and children with tracheostomy in their own homes, where the grim alternative would have been a long-term stay in intensive care. I have also personally worked with some patients at home that came from intensive care directly, and we would take care of them in an intensive home care environment and provide those patients with the care, the dignity and the privacy they and their families wanted in such a unique and once-in-a-lifetime situation. Families who decided to take their critically ill loved one home at the end of their life generally experience a deeper sense of meaning of their loved one's death, and they therefore felt like they had peace of mind, control, power and influence. Once again, check out intensivecareathome.com.au for more information. I really hope that this video has served you well, and I hope that you have gained even more insight of how you can effectively deal with your fears, frustrations, your struggles, your vulnerability, and how you can turn the situation around so that you will feel powerful, in control, influential, and so that you can have peace of mind. You will also be mentally well positioned and mentally strong to deal with this situation. Hopefully, I was able to elevate your thinking and also to lift your spirits. I also hope that I will see you in our other videos, or that you read our other ebooks, so that you can find even more strength, more power, more energy, greater influence, and also hope in your challenging journey through the intensive care landscape. For more information on a variety of topics within intensive care, check out more of our reports, ebooks, videos and audios, and also read our blog for more tips and strategies. And don't forget the Your Questions Answered section. You can find the links on our website. Thank you so much for watching this video, and I'll see you again in another video soon. This is Patrick Hutzel from IntensiveCareHotline.com.